drug effect of pain medications, being hungry for cakes and sweets is a side effect of the corticosteroids. So you really have to counter that. What's the other place where you may have a patient who's eating more than usual? What population do we say tends to gain weight? Yes. And so what happens is you're going to have more people who may be eating more than usual. Sometimes it's because they may be getting corticosteroids. Sometimes it's because they've talked among themselves and they find that they have less nausea if they kind of nibble throughout the whole day. There are a lot of different reasons why it happens. But again, this is a way that you can also have an impact on looking at your women with breast cancer and not just people who are losing weight. So those are the two populations. If you see that. Or the third one is they've had really good interaction with the dietitian or nutritionist and they're getting better from that standpoint.
I think this one may speak very for itself. All symptoms that are present in terms of have occurred in the past month.
The one thing I will say about that is, again, as dietitians or nutritionists or professionals in general, we tend to overthink things. And so I've had dietitians say, well, it says during the last month or the last 2 weeks. So what happens is, I don't think their pain really kept them from eating. It wasn't in their mouth. It wasn't someplace. No, some people who have pain just don't eat because they feel poorly. So the patients are very good at knowing what these questions mean. It doesn't mean that they have to have it the whole 2 weeks. It doesn't mean that you have to decide whether it had an impact on their eating or not. It's what they, as the patient, does. And sometimes I've had dietitians who said, oh, it has to be present the whole 2 weeks. No, it's just saying, in the last 2 weeks, have any of these things happened that have had an impact on your ability to eat? The other thing is for the others, even if you include problems with teeth, depression, finances, even if you list all three, you get 1 point. So just as one additional thing. But again, those are all things that can have a difference. I think we've covered all of those.
Any questions?
The one about this, I think this one's particularly good for a couple of different reasons. If you're going to do any outcomes-based research, if you want to see what happens to all of your lung cancer patients, you've got that right here. If you're going to look to see what happens to stage 4, patients who have stage 4 cancer, you've got it here. You don't have to go back to another chart. So you have all of this here. Also, in terms of stage of disease, where we put other, most people would say 1 through 4 has to do with cancer. Yes, those are the only ones that you can have for cancer. But there are different stages of kidney disease. So if somebody has a CKD stage 3, you can put that there. So if that's the underlying problem, you can actually put that there. So this is really your mini medical record to know what's going on that can have the impact on outcomes. So it works from that standpoint. So when you're doing all of your research at the end, you can say, these may be the reasons this happened. The other thing, because see, I'm hoping all of you are going to do abstracts for things so that you'll have the data there. The other thing, when we look at cancer, HIV, cardiac cachexia, you had some questions about cardiac disease. Cardiac cachexia or pulmonary cachexia, open wounds, fistulas, etc. All of these things here, except for age over 65, are things that increase metabolic or the catabolic risks for the patient. If you put other ones that again, we have, they list other, and I don't see this, that's the other stage, that's not the other thing. Anyway, so the reality is that if you have another disease and you want to put it there, you can. That's where all, I knew there was
sorry.
That's where you can put other ones, so that if there's something other than those check-off ones, you can put them on that top one. If somebody has something where there's really not much, they have another disease, it's fine, you can put it there. But if it really doesn't have much of a metabolic component, you wouldn't necessarily add an extra point for that. Say it in Portuguese, so everybody can hear.
A minha pergunta em português é quando há uma deficiência de sutura, se nós podemos utilizar aquele quadradinho da úlcera ou da ferida aberta. Muitas vezes são deficiências que não estão abertas, mas é metabólico o problema.
She asked when it happens anastomosis rupture,
Yes?
where do you put it? In ulcer, for example?
Yes, I would probably put it under the decubitus or fistula, etc. I think an anastomotic breakdown, that would be a perfect place to put it, because again, that's someone who's going to be highly inflammatory because of the cytokines, the sepsis, etc. So that would be someone who has an anastomotic breakdown. Absolutely, that would be a place to put it, or you could put it in other and give it 1 point there. Either one of those would work. Excellent question. Anybody else? I think those are pretty straightforward. The next one. Again, this is one I mentioned when we were talking before. So can I have the clicker? So if in fact I had somebody who had a very high fever, but it was short duration, this would be 3 points, and this would be 1 point. So they get 3 points here. If it's somebody who has a low grade, a low temperature elevation, say 38.3, but they've had it for more hours, this would be 3 hours. It would be 3 points. So you don't add these two together. So if this was 3 points here and this is 3 points here, they only get 3 points. Okay? So it addresses that. And again, the corticosteroids, what's very interesting to me is for years, this had the greater than 10 prednisone equivalents per day. It's amazing how many times nobody ever asked, how do I get that information? So it's actually built in the app. We actually have it on the website. And there were people who asked, but I was kind of surprised the number of people who didn't ask when they were using it. But those are 3 things. And again, as I said, the most common cause of drug-related muscle loss is because of corticosteroids. And sometimes people will say, I'll just do it a little bit for an appetite stimulant, but it really does exacerbate the muscle loss. Go ahead. You're asking questions, that's good.
Quando os doentes...
It's on. Just go ahead and put it here.
Bom, quando os doentes têm doses baixas daquelas bombas que são vasodilatadoras dos brônquios, e tenho doentes com 1 ou 2 ou 3 bombas, das quais só uma é que tem equivalente a cortisona, nós consideramos dose baixa ou dose moderada?
How we consider those when the patient's doing 3 or 4 bronchodilator pumps with corticosteroids, and only one has the equivalent in corticosteroids and the others don't say anything.
Okay. Again, it's a really interesting point in terms of bronchodilators. Something we should think about in terms of coming up with adding that to it, because I think a lot of times people don't realize that you can have significant systemic uptake of inhaled corticosteroids. So maybe we can put that on our list to think about. If we went to the, I don't know, do the corticosteroids come up? No. We don't have the list? No. Some of the ones that are in that list actually can be used as inhaled, and you get similar kinds of levels within the blood if you take it orally or you take it IV or you take it the other way. But I think it's the first time that question's ever come up, so I'm going to have to think about it and how we can better add it to it. I mean, this is one of the things I love about talking to people. A lot of times people keep asking the same questions. But if you go to enough places, somebody's going to come up with a new question. Yes, I have to know that answer. So So next time, if you see it there, you'll know you had something to do with that. You're welcome. Again, we've talked about this. This is just kind of a way of helping. The maximum point scores is 3. Don't worry about it. Whatever it is, it's probably going to be okay. And again, knowing that 90% or so of the score is in the part that the patient does and not what you're doing, this just makes you think about it, but it doesn't necessarily make a major difference. I'm turning it over to her now. Not her, Harriet. See, she says she doesn't have much to say, but I think that's not true.
Eu costumo utilizar o stress baixo quando eles usam 1 a 2 bombas. E quando usam mais de 2 bombas, põem o stress moderado, se as bombas estiverem cortisol. E pronto, era para ela saber, não, já agora.
She's saying that she used low stress score when they use 2 pumps.
Okay.
And moderate stress score when they use more than 2 pumps, and they all have cortisol.
I think it's a reasonable first choice. It may tend to overestimate a little bit, but again, I think the fact that you're considering it and including it, if there's somebody who's like at this level and say they've got 8 points, that putting them on the corticosteroids puts them over the 9 points, and it's really trying to understand where the risk is. So I think if you overestimate a little bit, I don't have